There we go. There we go.
Okay. All right, so like I said, we'll start out pretty basic. So with that, what is breathing? Well, breathing is really the simple process of taking air into and expelling it from the lungs. It's a simple process of moving a fluid. In this case, we normally think of fluid as a liquid. However, gas can also be considered a fluid as well. And when it comes to inhalation versus exhalation, a lot of times when talking to a patient, they can get very confused with the inhalation or exhalation portion, because sometimes they may not totally understand the term, or they're just not paying attention. So I will generally use breathing in and breathing out to describe the action that I want them to perform. Just it's a little bit easier for them, and they catch on a little bit better. So now let's take a quick look at the respiratory anatomy. Let me put my pointer on. So when it comes to breathing, we'll start at your nasal and oral cavity, and then we'll follow the airflow through the pharynx, down through your trachea into your bronchus. You have your left and right main stem bronchus, and that'll divide into your bronchi and bronchioles. And from there, it'll eventually get down into your alveoli, the base unit for gas exchange within the lung. We have three primary lobes in your right lung. We have your superior, middle, and inferior lobes. And then on the left lung, we have your superior and inferior lobes, making room for the heart on this side of the body. Now we'll take a quick look at some medical measurements that we like to use in the respiratory world. We'll normally reference millimeters of mercury, abbreviated as mmHg. This is something that you would see when it comes to taking a blood pressure. That 120/80 is measured in millimeters of mercury. We also see that in intracranial pressures, and we use it a lot in mechanical ventilation. We'll be referring to atmospheric pressure, and at sea level, our atmospheric pressure is 760 millimeters of mercury. Also, we will refer to that as our barometric pressure, abbreviated as PB. Another measurement that we like to use specifically in the respiratory world is centimeters of water pressure, or CWP. It's something that you really don't see outside of the respiratory world as often. And what we're talking about is literally, if you look at this picture over here on the right side of the screen, if we were to connect a high pressure machine, a CPAP, BiPAP, or mechanical ventilator here, this U barometer has water here on the bottom section, and it's literally the amount of pressure that it takes to move this water up 1 centimeter from this 6 line to 5. So that's what centimeters of water pressure is, and a lot of times we'll use this in mechanical ventilation and CPAP and BiPAP. So they'll be on a 10 centimeters of water pressure, or CPAP of 10, and that's what that pressure is. Another rule that we'll refer to throughout this presentation is the rule of gases. And basically what we're saying here is that a gas will always move from a higher pressure to a lower pressure until it reaches equilibrium. And we'll refer to that a few times. So we're going to zoom in a little bit further and look at the internal anatomy of our thoracic wall in our lungs. So here we have the thoracic wall, and then we have your diaphragm. And on the inside here we have your nice pink lungs, and then we have this gray space. This gray space is your pleural cavity. And so on the outside of the lungs, we have the atmospheric pressure of 760, as you can see referred to here at the bottom. And as we've mentioned, that rule of gases, that will always move from a high pressure to a low pressure. As they move into the lungs, we can see that pressure matches at 760. And as we're born, our thoracic cavity actually grows faster than our lungs do. So it actually develops a negative pressure in this pleural cavity. So we can see here that cavity has a barometric pressure of about 756. So it's about 4 millimeters of mercury less than what's actually inside our lungs. And this helps to keep our lungs expanded so that they don't collapse onto each other, causing like a pneumothorax. If this cavity is actually punctured or ruptured, that's what causes the pneumothorax to occur, that collapsed lung. The pressures equalize and the lung actually collapses on itself. And so again, that atmospheric pressure, that barometric pressure is 760, and that is your transpulmonary pressure is the actual pressure that matches the exterior atmospheric pressure to the interior pressure of the lungs. So back in 1802, John Dalton was a physicist, and he published his law on partial pressures. And John Dalton's law says that the total pressure of a mixture of gases is equal to the sum of the partial pressures of the component gases. Now, that's a mouthful of words, but what exactly does that mean? Well, what John is saying is that if you take pressure three different gases, and you take the pressure exerted on the atmosphere from each gas, you take the pressure 1 plus the pressure 2 plus pressure 3, you'll get the total pressure. So let's abandon this idea of gases and pressures for a minute, and we'll just talk about volumes. It's easier, we use volumes more on a daily basis. So if you have a cup of 250 milliliters of water, and you have a cup of 250 milliliters of tea, and a cup of 250 milliliters of lemonade, and you mix all three together, what John is saying is that you'll have a total volume of 750 milliliters. So you just take that pressure 1 plus pressure 2 plus pressure 3, and that will give you your total pressure. So it's a pretty simple concept, but back in 1802, this was a brand new idea. So how does this apply to us as healthcare professionals? Well, if we take Dalton's law and we break that down into our current atmosphere, we said that our atmospheric pressure is 760 millimeters of mercury. And we have many different gases in our atmosphere. Here on the left side of the screen, we see nitrogen, oxygen, argon, carbon dioxide, and there are a couple other trace gases that are make up our atmosphere, but we're going to leave those out just for simplicity. And we can see the partial pressures of each of those gases on the right side of the screen. Nitrogen has a partial pressure of 593. Oxygen has a partial pressure of 159, and if we add all of these up, guess what we come to? We come to that total pressure, atmospheric pressure of about 760. It's a little bit less, but because we left off those extra gases. Now, if we take the partial pressure of each gas, say nitrogen, and we divide that into our 760, that gives us the percent of atmosphere that we actually have of nitrogen. So nitrogen makes up about 78% of our atmosphere. Oxygen makes up about 21% of our oxygen in the atmosphere. So when it comes to these partial pressures and the percent of atmosphere, I asked the question, how does this apply to us as healthcare professionals? Well, if we zone in on this 21% that we see of oxygen, where have we seen that when it comes to us as our profession? Well, when we document room air, we document that somebody is on 21% FiO2. And that's where this number comes from. That's where we see that. Now, if we have a patient that is desatting for some reason, they need to be placed on supplemental oxygen. We have a patient that's at 87%, we go ahead and we'll normally place them on a nasal cannula, maybe put it at 2 liters. What have we done? Well, we have literally taken this partial pressure, washed out some of the extra gases that are in the atmosphere, and just replaced it with oxygen. So now we've taken the percent atmosphere and we've increased that percent to a higher concentration. Now at 2 liters, you're at 28% FiO2. And this will continue to increase by increments of 4 for every liter flow. So 3 liters is 32%, 4 liters is 36%, all the way up until 6 liters, which is 44% FiO2, that fraction of inspired oxygen. Now, if we were to change out that interface, say we put them on a simple mask, they would, at 8 liters, they would have an guesstimated FiO2 of about 60%. And then again, if we were to swap that out for a non-rebreather mask, we're going to be totally washing out most of the other atmospheric gases with primarily just oxygen. At 10 to 15 liters, that patient is going to be receiving about 95% FiO2. Just as a side point, when it comes to a non-rebreather mask, we want to make sure that we are using 6 liters and above to deliver oxygen with the non-rebreather mask, because anything less than that, the patient will be rebreathing their own CO2, which actually would have more of an adverse effect. I can't tell you how many times I've walked in on a rapid response and we have a patient that's on a non-rebreather mask, but they're only receiving 2 liters, and they're wondering why their patient is lethargic. So that's something just to keep in the back of your mind. So we've talked about these partial pressures here and the percent of atmosphere and how this can change based upon how much oxygen we're delivering to someone. But can this percent of atmosphere actually change based on our physical location? Well, if we look at this slide here, this shows our current elevation in meters. So at sea level, at 0, our barometric pressure, atmospheric pressure, is 760 millimeters of mercury, and our PaO2, that of oxygen, that partial pressure of oxygen, is 159. As we increase in altitude, our barometric pressure drops, and our PaO2, the partial pressure that's exerted by oxygen, will also drop. So as we increase, the partial pressure will decrease as well on those gases. So just for example, Denver is about 1,600 meters above sea level. So they're going to be falling right in here, probably about that 630 range in their barometric pressure. Now Everest is on the opposite end of the scale, and that's almost coming in at like 9,000 meters above sea level. So their barometric pressure is going to be significantly less. So we can see that this pressure changes, the partial pressure changes, but what about the percent of atmosphere? Does that remain the same, or does that change as well? So let me stop sharing here and go on to okay. So I have my handy dandy suction canister here full of M&Ms, keeping it with the respiratory theme. So we have each of these M&Ms here is representing a different molecule of gas in our atmosphere. So at sea level, we have 78% of nitrogen, which is represented by the yellow, orange, and brown M&Ms. Our oxygen is represented by the blue M&Ms, so we have about 21% blue M&Ms in this 800 cc canister. And we have a few trace gases in here as well, represented by red M&Ms that you probably really won't see. There's a couple there. But you can see that each of these M&Ms is really tightly fit in this canister. So this represents the fact that the partial pressure is higher at sea level, because all of the pressure, all the molecules are exerting a pressure on each other, a force. Now, as you increase in elevation, we have another canister with the same amount of M&Ms, or a similar amount of M&Ms per ratio of gas. So we have nitrogen, again, represented by the yellow, brown, and orange M&Ms. Blue is it's hard to see here in the picture. You have the blue M&Ms representing your oxygen, and then we have one red M&M in here. So we can see there's a lot more volume, or more space in here for the molecules to bounce around. So therefore the pressure is exerted. So generally, if these were air molecules, they would be bouncing around in here, not all hanging down at the bottom. But you get the idea that there's a lot of room for movement in this canister. So the ratio stays the same. So there is still 78% nitrogen in this canister and 21% oxygen. However, there's more space for the molecules to move around. So if we go back to our PowerPoint, share. Okay, and we move to the next slide, we can see how this will affect us specifically in transport scenarios. So here at sea level, we can see how close-knit these molecules are, these oxygen molecules. But as we increase in elevation, the space between the molecules actually reduces or increases. So there's more space in between the molecules. Now, as we get up to higher elevations, we can see there's a lot of space in between the molecules. However, in every scenario, in every portion of this elevation, the ratio, the 21% oxygen, will remain the same. However, the partial pressure that's exerted on each molecule is different. Now, this can be slightly confusing, but until we put it in a scenario, say we're transporting our patient from Ohio to Denver, we may need to increase our their oxygen requirements may need to increase as we increase our elevation, because that partial pressure, they're getting less room air entrained, that partial pressure is slightly less, so they're going to need more oxygen, supplemental oxygen, as they increase in elevation. Okay, so we've talked about atmospheric pressure and how it affects partial pressures outside of the body. Now let's look at how it affects the inside of the body, and specifically in our lungs. So again, we have that partial pressure listed as 159, as in our dry air, and that carbon dioxide is 0.2. Now if we take it inside the body and look at the alveolar space, this has decreased. Each of these has decreased. We have a partial pressure of oxygen at 100 and a partial CO2 pressure of CO2 at 40. Why has it decreased? Why has our oxygen decreased and our CO2 all of a sudden had a giant increase? Well, part of the reason for the loss in oxygen is water vapor. It's going to be pushed out slightly by other gases, but then also you notice this CO2 has increased. Why are we seeing an increase in CO2? Let's take a look at this next slide. This is a very confusing slide, but we're going to break it down to answer that question a little bit easier. So if we look at this this image here, we're actually looking at the heart and the blood flow through this the systemic system. We have oxygenated blood here coming from the lungs. It's being pumped through the arteries down into until it exits out the heart into the cellular tissues, and then the cellular tissues are metabolizing that oxygen, giving the red blood cells their waste, and it's coming back to through the heart, being pumped out to the lungs again. And so this is where we have that metabolic exchange. So here we see our atmospheric pressure at 160. They've increased it to 160 instead of 159. But and then we take these numbers, the PO2 and the PCO2, and we implement that here in the alveoli, in this picture of the alveoli. Again, the rule of gases. They're going to go from a higher concentration to a lower concentration. So your red blood cells are coming all used up. They have no oxygen, but they're carrying the CO2 as the waste product from your cells. They're dropping that off, and that until it reaches equilibrium. So if it's at 46, our PCO2 inside of the alveoli is only 40. So that extra pressure is transitioning over to the alveolus until it creates an equilibrium. And then are now taking up oxygen, because their oxygen at this point was only 40. So now that 100% that we have, that our partial pressure of 100, is transitioning over to our red blood cell, and it's actually uptaking that oxygen, and it's going to transport that out to the rest of our cells. So like I said, it's a little bit confusing, and we spent a lot of time on this in school, but as just a brief overview, what you need to know is the fact that the red blood cells are dropping off CO2, they're taking up oxygen, and then what's happening is at this point we're expelling the CO2 through the respiratory system, and so that's why you're having a higher CO2 here inside of your lungs compared to the outside. And so it's a waste product from metabolism. So, and how this all applies to us as respiratory therapists and other healthcare professionals is specifically comes down to blood gases. Respiratory therapists and physicians will use a blood gas as a spot check to see how well a patient is ventilating. If we primarily focus on the pH, the PaO2, and the PaCO2, your partial pressures of carbon dioxide, partial pressure of oxygen, we will see some numbers that are what we've been, that are familiar to us through our discussion. We have a PaO2 of 100, which we saw was from our atmospheric pressures into the lungs. It dropped down to 100. And then right in the smack dab in the middle of 35 to 45, we have a PaCO2 for a partial pressure of carbon dioxide of about 40. And so this is where that average comes from. This is how we interpret blood gases to see whether or not someone is adequately ventilating or not. We look to, if those ranges are out of whack, we can make adjustments based on this. Another thing that we'll notice here is also with the blood gas is our oxygen saturation. We can see how full the red blood cell is, like similar to using the pulse ox on your finger. This will determine whether or not what your oxygen saturation is for your patients. Now, if you really want to get scientific and impress your physician or your respiratory therapist, you can whip out the term oxyhemoglobin dissociation curve. This is a very confusing principle, but we'll break it down pretty simply, that here at the bottom, we have your partial pressure of oxygen compared to your oxygen saturation that you would receive on your pulse ox. So basically, this is comparing blood gas results to oxygen saturation results from your pulse ox. We can see that 80 to 100 on your PO2 or PaO2 is up here in your 90 to 100. You can see how there's not a whole lot of change here based on how much oxygen you have in your system. So if we're just flooding somebody with a whole bunch of oxygen, say we've got them on 15 liters of oxygen and their PaO2 is 600, you're actually going to have, you're not going to have much benefit over what 100 is. Now, however, on the flip side, if we drop below this 80 and go down to 60 or 50, we can see that your saturations are really going to drop off once you get below those portions, that you're going to be about at a SpO2 oxygen saturation of about 83 at a PaO2 of 50. So again, this is something that isn't, I'm not expecting you to totally grasp here and to remember, but it is a nice relation to how atmospheric pressures relate to blood gases, which then in turn relate to how we will manipulate and manage someone's care when it comes to mechanical ventilation. So let's move on into our respiratory diseases. Respiratory diseases can be broken down into two primary categories, obstructive and restrictive. Obstructive diseases are a disease that causes shortness of breath due to the inability to completely exhale air from the lungs, whereas a restrictive disease is exactly that. It restricts the lungs from fully expanding so that they can't get the full amount of air that they're supposed to. So we'll examine a few obstructive diseases first. Asthma is one that is very common. Lots of people suffer from asthma. And this is characterized by a reversible airway obstruction and hyperreactive airways. And really what that means is that inflammation. If you have cuts or an inflammation on somewhere else on the outside of your body, what happens? It gets red and it swells up. Well, when an irritant hits the airway for someone who is asthmatic, it actually takes the airway that is nice and open and it actually inflames and causes a restriction. So now you have a smaller airway to breathe through. And so a lot of times what you'll see with this is something that we call it bronchospasms. And if you have a twitching muscle, that's what is happening. Your airway is really twitching and it's unpleasant, and it causes this weird sensation for the patient, and they'll start coughing. So you'll have those bronchospasms. You'll hear wheezing that when they inhale, you'll have that, you'll hear that as they're breathing in. You'll see a lot of secretions as well, because now your airway is irritated, and so what it does to protect itself is it normally you'll have more mucus, and so you'll see a lot of them coughing up a lot of mucus, and you may even see some mucus plugging with that. This often has a rapid onset, so it can be diagnosed as mild, moderate, or severe using a peak flow meter. This is your standard for measuring how severe of a case of an exacerbation you're having. So you'll want to use that peak flow meter on a regular basis. This is something that is really underutilized for asthmatics, and a lot of asthmatics that I've come across have never even come into contact with a peak flow meter, and so it can actually be very life-threatening for them if they're not monitoring that, especially if you have a severe asthmatic and they're not monitoring their peak flows on a regular basis. So how do we treat asthma? Well, it can be you can have medication therapies. You can use your nebulizer or your inhalers. Usually albuterol and Atrovent will be one that we'll see very commonly with a nebulizer. You may have an albuterol inhaler or a Combivent inhaler, which is albuterol and Atrovent mixed together in an inhaler form. Xopenex might be used for those who suffer from higher heart rates. So albuterol has a tendency or a side effect to increase your heart rate. So if you already have someone who is anxious and their heart rate is extremely elevated, we don't want to continue to elevate it, you can use the medication called Xopenex. I've gotten asked a lot of times which delivery system is better for a patient, and it really all comes down to how your patient is doing and if they can perform proper technique with an inhaler or a nebulizer. Honestly, your MDI. So honestly, your MDI is going to be the better of the two. You're actually going to receive 3 to 4 times the amount of medication with proper technique of using an inhaler. But for our patients that are in severe distress, a nebulizer is usually the way to go, because they don't have to concentrate and worry about proper technique. Because with proper technique with an inhaler, you're going to inhale, have a breath hold for 10 seconds, and then exhale and repeat the process. With somebody that's having an exacerbation, most of the time, asking them to hold their breath, they're going to look at you like you're crazy, because they're not going to be able to do it. So the nebulizer, you're actually only really receiving about 12% of the medication that's nebulized through the nebulizer, and where your MDI, your inhaler with proper technique, you're going to be getting more, that 27 to 35% of the medication per puff. So you're getting significantly more. However, it just depends on the situation and what your patient and how your patient is able to tolerate either of the therapies. Another way to help reduce exacerbations when it comes to asthma is just to prevent exposure. If you know that you have problems with cutting the grass or pet dander, try to eliminate those as much as possible. Or if you know that you're going to be in a situation where you're in contact with those irritants, go ahead and take your medication before, because that's going to relax your airways, and that medication's already going to be on board, so that when those irritants do irritate your airway, there isn't as much constriction and irritation. And in really severe cases, you're going to have possibly intubation and mechanical ventilation. We're going to want to try to avoid this with asthmatics as much as possible. However, sometimes it does come down to that. The next obstructive airway or obstructive disease that we're going to look into is COPD, chronic obstructive pulmonary disease. The American Thoracic Society classifies COPD as both emphysema and bronchitis, so having a combination of both diseases. However, really, the being diagnosed with COPD, you can only really do this with a pulmonary function test. A lot of doctors will just slap the COPD diagnosis on patients that have emphysema and chronic bronchitis, but really to diagnose the true disease, you have to have that pulmonary function test done, which will measure specific volumes in your lungs. And this is a process. It's a pretty simple outpatient process that can be done. You can go in, they'll do these different measurements of your lungs by doing different breathing exercises, and then at that point, the physicians, the pulmonologists will evaluate the data and then let you know whether or not you have COPD or not. Signs and symptoms of COPD, obviously shortness of breath, wheezing again, increased sputum production and chronic sputum production. It's going to be that every morning waking up and coughing that they just keep hacking and it's real thick and nasty. You may notice cyanosis on their fingertips. They may have a little blue tint to them. Digital clubbing will happen over years, and this is literally a kind of a squaring off of the fingertips and toes because your body is trying to take that perfusion from your periphery and keep it close to the body because of the lack of O2 throughout, lack of continuous O2 over the years. So COPD is the number 3 killer in America right now, second to heart failure. Well, guess what causes heart failure? COPD. So COPD causes right-sided heart failure, that your cor pulmonale, and then also another symptom that sign that you would see with COPD is a barrel chest. So we've talked about how obstructive diseases don't let you fully exhale. So over years and years, your body adjusts to that. And what will happen is they will develop this big barrel chest from continually not exhaling their full lung volume. And unfortunately, there is no cure for COPD. There is only a maintaining of the current life status. So you can do medication therapies and other treatments that we'll talk about here in a minute, but unfortunately there is no fix for that COPD. Once you've got it, you just have to maintain that that standard of life, that standard of care at that point in time. So specific treatments for COPD, we talked about bronchodilators, your albuterol and Atrovent. Those will dilate your airways to help more flow for your breathing. We'll talk about inhaled steroids. Advair and Flovent are common inhaled steroids. As a side note, this is something that you're going to want, that COPD patients are going to want to use on a regular basis. They don't want to start and stop them consistently because these steroids take about 2 weeks to accumulate in the system and for them to really start to affect your body. These are not like your oral steroids that you get and you get your high dose from your physician to treat other infections or things like that. These are a maintenance drug, so they're going to want to be used consistently over a period of time. If you miss a dose here or there, it's okay, not ideal. However, you want, like I said, you want to keep that in your system over a period of time. Oxygen therapy. Oh my goodness, with COPD patients, this is a huge controversy. We're worried about oxygen toxicity, knocking out their hypoxic drive. How does this come into play? Well, we'll talk about that in just a second. Pulmonary rehab. This is kind of like going to the gym for your COPD patients. They go to this pulmonary rehab, they do some exercises to help strengthen their muscles, to get them used to exercise, to get their lungs reconditioned and to better and more efficiently use what they have available to them. BiPAP therapy, this is something that we'll use for ventilation. This is different than CPAP. BiPAP uses 2 pressures, where CPAP only uses 1 pressure. Your CPAP will be a pressure that's above baseline. So that's those centimeters of water pressure. We'll have 5 centimeters of water pressure with a CPAP to help open up and stint your airways open. And then that BiPAP will have 2 pressures, an inhalation pressure, so that that IPAP, which will be higher than whatever your CPAP is set at. And this will help you take a nice big deep breath in and then blow off that CO2 that is building up in your system, as is commonly known for COPDers. Mechanical ventilation may be a necessity with severe exacerbations of COPD. So that hypoxic drive, what is hypoxic drive, and how do we, how as healthcare professionals do we keep this in mind so that we don't hurt the patients that have COPD? Well, first thing is, not all COPD patients are CO2 retainers. So that's something that we need to keep in mind. So what happens with COPD is, over time, you're not fully exhaling your full breath, that obstructive disease, and you have a buildup of carbon dioxide in your system. So we're looking at going back to those barometric pressures and that millimeters of mercury. We had that blood gas value of about 40. So you're going to see a CO2 level in their system. Over time, it's going to raise. So it may be 46, 50, 55, 60, and at some point, everybody's different. There's no exact number, but at some point, your body will differentiate the way it takes its breath. Normally, how a normal person works is that your body recognizes that, hey, my CO2 levels are increasing in my bloodstream, so I need to take a breath to exhale some of that CO2 and blow that off. So your level starts to build up, 46, 47, and your body says, hey, I need to take a breath. So you take a breath, and now your CO2 levels have gone back down to 40. Well, at some point with the CO2 retention, your COPD patients, that flips, and your body no longer registers that high CO2 as the key to stimulate breath. Now what it'll say is, hey, my oxygen level is starting to get too low. So as my oxygen level decreases, at a certain point, I'm going to need to take a breath. And so at 87%, 86%, 85%, it says, hey, I need to take a breath. And then I take a breath, and now my oxygen levels increase, and then they start to slowly taper down again. So that's how it works for a COPD patient that has that hypoxic drive. So if we take, say we get somebody on a squad or in a facility, and then all of a sudden we see that their oxygen levels, we have the pulse ox on them, and we see that their oxygen level is 85%, and we freak out and we say, hey, we need to put them on 4 liters of oxygen. So we put them on 4 liters of oxygen to raise their SpO2. We get it up to 93, 94%. Hey, we're doing good. But all of a sudden, we realize our patient isn't breathing. Well, that's because we've knocked out their hypoxic drive by increasing their oxygen levels. How does that work in their bloodstream? That those O2 levels, right, they're starting to taper off until their body kicks in and registers that they need to take a breath. Well, now we've added this supplemental oxygen, so their oxygen level is always high. They're never meeting that point where their body registers, hey, I need to take a breath. And so they're not breathing because of that. So how can we know? Honestly, there's no way to look at somebody and say, hey, you're a CO2 retainer. Could we look at a blood gas? Yes. If we have one available to us, we may be able to see, but just because they have an elevated CO2 doesn't mean that they're going to be operating off of their hypoxic drive. It's just kind of one of those things that we have to be mindful of. We can't pinpoint anybody specifically unless they're a documented CO2 retainer with that in this case, that knocks out their hypoxic drive. So a good rule of thumb is to keep CO2 or COPD patients at that 88 to 92% SpO2 and just monitor them so that we're not knocking out their drive if they are a CO2 retainer. Now we'll move on to restrictive lung diseases. So we've talked about how restrictive lung diseases are diseases that limit the patient from getting air in. And so this may be somebody that has a physical deformity, such as kyphoscoliosis. They may have some scar tissue in their lungs, commonly known as pulmonary fibrosis. You figure if we have scar tissue on the outside of our body, what happens to that if we have a nice deep cut on our hand? Over time, it heals up, and you may have scar tissue. Well, that's harder and thicker and uglier than the rest of the tissue around it, and that happens in the lungs as well. So we may have that barrier where the oxygen crosses over into the bloodstream. That may be scarred, thick, and hard, and so it's going to be harder for those gases to cross that blood barrier in the alveoli. Obesity is another restrictive lung disease. Patients are getting bigger and bigger and bigger. And as they lean back or if they move, the physical weight that is on their chest restricts the amount of movement that is available, depending on how strong their lung muscles are and their physical muscles in your thoracic cage. It will limit the ability that the patient has to take in a nice full breath. Neuromuscular diseases is another restrictive disease, such as myasthenia gravis or muscular dystrophy. Myasthenia gravis actually causes it's a progressive disease that will start at the head and slowly work its way down to the feet, and it will you'll slowly have reduced ability in all your functions. So you may have at that point, you may have a limited ability to take in a nice big deep breath. And so a lot of these patients will have BiPAP, CPAP machines, or may even be on a non-invasive ventilator or an invasive ventilator through a tracheostomy. As we said, treatment will vary based on the condition. So they may be using that CPAP or BiPAP machine. They may be using a sip vent. So they'll have a little straw that comes up, and they can lean over and take a quick sip, and it just gives them a nice big breath in to help with that neuromuscular disease. They may be on a very varying medication regimen, so they may be getting bronchodilators and steroids as well, but it's a pretty much a case-by-case basis when it comes to restrictive lung diseases. We talked about that collapsed lung in the very beginning when we were talking about the atmospheric pressures. So if something were to come in and break that pleural cavity, whether it's a knife or a gunshot, or maybe someone that has a disease coughs the wrong way. A lot of times we'll have patients with cystic fibrosis who have these really hard and long coughing spells, and they're just hacking away, and next thing you know, they've ruptured their pleural space because of just the how frail they are as in their disease process, but then also the weakened pleural cavity. And so when that happens, those pressures reach equilibrium, and it actually causes the lung to collapse on itself. Treatment for this would be using, well, first off, if there's a physical impalement or something like that, we would want to remove that. And then on top of that, we would probably be using chest tubes, which have a vacuum pressure, which will cause a negative pressure in this pleural space and allow the lung to reinflate on itself. PEEP is positive end expiratory pressure, and this is something that we use in invasive ventilation, and which is, so in non-invasive ventilation, it will be labeled as CPAP. In invasive ventilation, it'll be labeled as PEEP, that positive end expiratory pressure. And we have a nice video here on this next slide that will show you rabbit lungs and how PEEP will affect a completely closed or uninflated lung. Oh, whoops. Will it play? There we go. So you can see how how when the lungs are completely deflated, they start to apply some pressure, those centimeters of water pressure through the airway. You can see that the lung starts to inflate. And so they're continuing to increase that centimeters of water pressure. So maybe they were at 5, now they're 7, and they keep increasing to 8, 9, 10. You can see how the lungs fully expand at that point in time. So that is PEEP. It's basically just that pressure to keep the airways splinted open at end expiration. Okay, and that's it. That was a quick review of the cardiopulmonary respiratory system and a few of the main diseases, respiratory diseases. So if you have any questions, please do not hesitate to ask.
Yeah, Brandon. My question is on the peak flow meter.
Mm-hmm.
You were talking about asthmatics; they need to monitor that. Is that something? Say, because I've had on my athletic teams, I've had some kids that have asthma, and they carry the inhalers with them, and
Sure.
usually the athletic trainer has access to those just in case. Would they also need to be carrying a peak flow meter with them in order to monitor that? Is that something that they should have?
So the doctor should prescribe them one when they are initially prescribing their inhalers and stuff. So, and they're developing their treatment plan, and it's a tube, and that tube is, I don't know if you've ever seen a peak flow meter.
No, I've never seen one. Yeah.
Let me see here. Let me pull this up real quick. And normally what we use in the hospital is something similar to this. And what they'll do is they'll take a nice big deep breath in, and they'll blow out as hard as they can. And it'll push and what this does is it monitors their flows per minute, their liters per minute of how much flow they can blow. And so this is something that they shouldn't necessarily be doing when they have their inhaler. They shouldn't necessarily have to keep it on them. But if they're a severe asthmatic and they know they have a lot of issues, they'd want to do this on a daily basis, because this peak flow meter would actually give them an indication as to where they're at if their airways are restricted at all. Because if you have an unrestricted airway, you're going to get high on this meter. So you're going to be up into the 300, 400, 500 range. Now, if you have a restriction and you actually have a tighter airway to blow through, you may be getting a lower flow rate. And so they may, if they're monitoring their flow rates on a regular basis, they would probably see this change in flows before they even feel any different in their airway. So before they even recognize, oh man, my chest feels tight, they would probably see that flow meter registered on the flow meter prior to that. Now, another thing that they want to use is a spacer for their inhalers. This is something that a lot of patients don't like to carry around with them. Some physicians will prescribe them, most don't, because what happens is they get thrown into a drawer in the kitchen and then forgotten about, and nobody ever uses them again. And what happens is if you take an inhaler and you actually shake it up and squeeze it, you will see a puff of medication, shoot way out here. And so it's about 6, 7, inches away from the inhaler. Well, if you take that and you physically put that up to your face and you squeeze that inhaler, that 6, 7 inches is past the back of your head. And so what happens is patients will say, oh, I taste the medication. Well, that's because what's happening is you have it here, you squeeze it, and it's going and it's hitting the back of your throat. And so they taste it at the back of their throat. It's not smoothly following their airway. And so that spacer, really, all it does is it applies a 6 to 7 inch gap in between the inhaler and the patient, allows them to take a nice, slow, deep breath in for a nice, smooth transition into the airway, so not all the medication is landing and depositing on their tongue and in the back of their throat. And that's really what allows for better medication deposition in the airway, is that smooth flow rather than that quick one. But people don't carry around the spacers because they're big and obnoxious, and they don't want to have to carry it around in their pocket or their purse or something like that. So when it comes to your sports patients, is it something that they should have? Maybe, but if they're not using it on a regular basis, it's going to be hard to tell, honestly, because they're not monitoring it with that peak flow meter.
Yeah, and I'm wondering if it's a good idea that, say, a hot August practice, a kid's getting ready to go out, the trainer knows that this isn't a kid who's had asthma issues. If she or he goes over to the kid and says, use this before you go to practice, and if she's monitoring it and she sees a drop, okay, you're not practicing today because we see a significant drop in your peak flow meter. If that's something they should be doing.
Yeah. So if actually that would be that would probably be very beneficial, because they before every practice or on a daily basis, if you know that this is a child that has, or just an asthmatic in general that has issues, have them use the peak flow meter for 30 days. And every day, just when they wake up in the morning, just go ahead and blow on it, record the value, and they can see the trends. And they can notate whether or not they were taking medication on this day or not. And that would be a good reference for you as the trainer to see. And then just before practice, if you know that, hey, it's that hot August day and this is probably going to affect you, then have them use their inhaler before practice, because it's easier to prevent it than it is to reverse it. And so if you have the ability to take the medication before practice, it's going to help. It's going to get your airway already in that relaxed state. And so if there is that inflammation for whatever reason, it's not going to be as bad as previously if you didn't take your medication.
Yep. Awesome. That's all I had. That's all
awesome.
I had. Yeah.
Great.
I want to thank you, Brandon. That was very, very good. Very good.
No problem.
Very, very informative, and I really like the way you explain things. It really kind of, I guess you could say, dumbs it down for me. So it was very, very easy to understand, and very good. So I appreciate it very much. So
no problem at all.
Yeah. Thank you for doing this, and I'm hoping we can continue this webinar series, and we can have you do some more too, because I know you're coming back for another one.
Yeah, in a couple of weeks, about CO2 and exhaled CO2 and how to monitor that as well.
Yeah. So I'll look forward to that. So, but thank you. I appreciate it.
You're very welcome. No problem at all.
All right. I'll be talking to you later. Thanks.
All right. Bye.
Bye.